Sutherland. I work at the Organization for Economic Cooperation and Development, otherwise known as the OECD. And what we're really struck with today is that for us to make progress with AI in healthcare, there is a significant barrier to that. Health as an industry is significantly lagging other sectors and has lagged other sectors with adoption of new digital tools and technologies for decades. And for some of that is for good reason. We have to care about safety. We have to care about people. We have to care about scalability. But some of that has manifest as unintended barriers, or sometimes intended barriers, that are actually preventing the good things that can come for people. And frankly, we're at a point where some of those barriers are causing harm. Because if our job with the Hippocratic Oath is to minimize harm, then we are not doing that job in health by preventing some of these tools and technologies being used. And so one of the things as we're talking through this is I'm going to highlight 3 areas where we can help navigate these dilemmas of trying to bring better public and private partnerships together. So the first I will talk about is moving fast while doing no harm, because that's really what we have to do. In the health sector, we have forces of the market which are trying to get us to move fast. We know how the second half of that sentence goes, but we try to move fast. We also have forces of the health sector that are trying to do no harm, because we have to live by the Hippocratic Oath. That's naturally what we do. There is, however, a third force, which is often forgotten, which is kind of weird because the force is us, the public. We are trying to make sure that we are coming together to make sure that we are scaling fast while we are doing no harm. And that is our overall objective of what we're trying to do in the health sector. And we need to remind ourselves that we are doing this not because we're trying to make our enterprises wealthy or we're trying to have stability of government. We're trying to do this to improve health outcomes for people. We are trying to minimize harm. And as we think about the potential of harm, and this is where I've heard repeatedly today that regulation we need to deregulate because it's causing, our inability to make progress, and I'll talk more about that later on. But this is a wheel that came out of some work in Alberta, Canada, where they developed a harms-based framework for data, more or less recognizing that there are harms that are created from data access and sharing and use, most notably through privacy protections, et cetera. But there are also harms that come from the non-use of data, the inability to find the next health outcomes, the inability to effectively improve the health system on a repeated basis. So once you recognize this, you recognize that you can never minimize risk to zero. It is a physical impossibility. There is always risk in the actions of providing access or not providing access. So our jobs become, how do we minimize the negative outcomes while optimizing the positive outcomes? And is finding that balance point that we have to do. It is too easy for us to say no to data sharing, because by saying that, we are causing harm. We need to have a more nuanced conversation that recognizes all the potential benefits and harms that can come from both action and inaction, and how do we optimize that? Point 2, how do we actually optimize our outcomes for the business sectors that we have versus people? So this, I expect I will be doing a test in this diagram later on, so when we go in the corridor. This is an actual process map in one jurisdiction for one innovator to gain access to one data asset. 130 steps, 44 handoffs, a year and a half, costing $50,000 to the innovator. And tell me how many startups could deal with that? How much innovation is happening in this environment? The answer is pretty easy. It's pretty round. It rhymes with bureau, or zero, as the case may be. And the problem that we have here is that everybody was operating within their own context, within their own institution. I'm optimizing for my institution. I am protecting reputational risk for my institution. So everybody was acting reasonably. I need to make sure there's great privacy protections to protect the risk of my institution. No one was accountable, and this is the real point, no one was accountable for the total outcome of better outcomes for a person. Everyone was accountable for better outcomes for my institution, not for people. And ultimately the question is, when we talk about data governance is not the act of governing and protecting the data. Data governance is the act of protecting people with the data. And we need to make sure there are clear accountabilities in our system that are encouraging and incenting that is the outcome. And frankly, very few governments and regimes have that. The Data Governance Act in Europe goes some part of the way there, but this is where, for example, in Canada, they've actually recently adopted a practice of health data stewardship. And that is something we see in jurisdictions like in the UK, where they have health data guardians, or in Australia, where they have a data commissioner, where they have a role that is a countervailing force of data should be used for good, and that is in balance with data should be protected at all costs. Those two things need to be held together. And I see some of this coming from the work of the HDS, where they have a practice where there's going to be a single door for research. My worry about the single door for research with the health data access bodies that are being created is that there will be 27 different interpretations of whatever version of the GDPR we have, most specifically in areas such as what we heard earlier on, public interest. And as a result, data protection officers not having a consistent definition will revert to, well, I'll protect the reputation of my institution. We need to make sure there is clear accountability for who is accountable for protecting outcomes of the patient, of the person. So that leads me to my third dilemma, because really, whose health data is it anyway? Because the public sector are the stewards of the health system and arguably stewards of public health data. Industry has the health and the human and technology resources in order to execute the biggest systems that we want, and they have the risk appetite for experimentation. Frankly, the public sector doesn't have that risk appetite. But there is a third section of this, and this is where public-private partnerships are fundamentally wrong. They need to be public-private person partnerships. We need to bring people into the question. So, because we need to understand for the public what are their wants and needs, and what is it that they need to see in the system in order to trust that the developments are actually appropriate. So that way they can express, this is what I need to see for trustworthiness, and I can tell you whether or not that worked. And this is where I'm very worried about the conversations around deregulation. Because regulation at a fundamental point is an expression of the will of the public. This is where regulation, through the stewards of the health system, listens to the public, puts on regulations for the innovators to make sure that they are developing things that the public expects and wants. We need necessary and sufficient regulation that achieves that expression of public values. And that is really where I think we can work together. So in those three areas, working together as defining who is accountable for the data, understanding that public and private partnerships need to work together with the public, and how we need to really balance those forces of market, public, and harm together. That is really what we need to balance our work going forward. So with that, I will stop, and I'll pass it on to you, Lynn.
Would you like me to do it?
So I'm a political scientist, so I'll be talking about governance and another perspective. So thank you for inviting me. Next, please. The EHDS is a policy document, and a policy document these are policy instruments, and they are living documents. They are documents for all the stakeholders and the governments which is being negotiated. It's also an expression of the government's ambition, and there's room for interpretation and room for in negotiations. Next, please. So these are, when we did a big EU project called EDITA, we actually managed to find that these are the regulations which are covering the health area, which is relevant for all the technologies which is going to be invented and implemented in health services in Europe. So it's not only the EHDS is part of all of these regulations. And if you want more in-depth analysis from us, you have to talk to me later, because I cannot present all the analysis we've done and how these interact and how these actually may influence on the governance of the implementation of e-health. Could I please next? So these are the thematic, we did a thematic analysis and we found all these themes, all these regulations are covering all these themes in various different aspects of it. And see, many of them actually covers the right of the citizen, the right of the natural persons, and rights of, so it actually emphasizes the rights of the citizens in Europe and covers and protects us. So this is, I've nearly finished my PhD on governance models in e-health, and what I see is that traditionally there's always been a negotiation between the government and the bottom up with the medical society, with the municipalities, the regions, the departments, and know what, and public actors. But we've also got some new actors coming on the scene, which will have to be part of the negotiations in the future of the implementation of particularly AI-supported services in the healthcare service. And that is the patients, as I said, the patients are, and the individuals, the citizens are, their rights are being really emphasized, and they got stronger rights in the system and also in the process, so they will be participating in the negotiation. And the market actors are also, you see all the actors here, all the stakeholders here, it's quite a big industry. So all of these actors are, will be negotiating the outcome of the policy on how to implement AI in policy in healthcare. So there's a dynamic there. So then this dynamic creates a hybrid governance model, because it actually moves in a process where public governance models need to include more private actors in and have a conversation, continuous conversation with the market and market actors, because the AI actually is more intrusive and more potent than traditional technologies such as the telephone, or when we used to do video conferencing in telemedicine and telecare in the 80s, 90s, and the early 2000s. So it's changed a lot. But the dilemmas of governance doesn't go away. There's always a dilemma around who is actually participating in these negotiations. Where is the voice of the citizen in these negotiations around what kind of data could you use to whatever solution you want to present? Maybe they're not part of the discussion, then they should be part of the discussion in order for us to have solutions and have systems which we have trust in. So these dilemmas on accountability, transparency in the decision systems, and even trust. I mean, in Europe we have healthcare systems which we have trust in, and we need to make sure that the implementation of AI actually is done in a way, like Eric says, that we just still keep the trust in our public healthcare and system and healthcare system. So as a researcher, I would say that the governance dilemmas, they don't go away, but they are probably more amplified, and they're even more important that we have a clear understanding that they are part of the dynamics all the time. Next, please. So this is just to show you why I'm saying what I'm saying. This is the governance structure of the EHDS. It's quite similar to the governance structure of the AI Act. But you see here that you have the inclusion of also the market actors, market surveillance, and the traditional public governance models. So, I mean, from my meetings with the Norwegian government officials, they're really struggling with the interpretation and implementation and inclusion of participants and stakeholders in the realization of the HDS in the future. So next. Thank you. So it's hard work, but I think that we can do it together. Thank you.
Thank you.